Okay then, let's make a start. Okay then, so for the final sort of session today, it's following your journey in terms of learning a little bit more about the brain, what goes wrong with the brain, and how potentially you can actually intervene and actually manage those patients and people living with those long-term conditions to improve their quality of life. So in essence, today we're focusing on dementia and Alzheimer's. And just a little caveat that Laura was going to present, but unfortunately she's been called away due to personal circumstances, so in essence you're stuck with me. So in essence, what is it that we want you to be thinking about and actually walking away from the lecture be able to actually demonstrate a knowledge of? And again, this is highlighted just for your reference, so when you're looking back and starting to plan revision and thinking about how you're going to prepare for those exams, what is it that you should think about going forward in terms of what this content should be able to illustrate to you, and indeed for you to actually successfully tick those learning objectives going forward. So if we think about dementia and Alzheimer's, you've probably all heard of those terms, and probably the two terms are interchangeable in your minds. In terms of dementia itself, that's an umbrella term, so that covers a whole host of diseases. So the word dementia itself covers the symptoms rather than the diseases per se. And in essence, up here on the slide, it shows you all the different types of dementia that people can suffer from. In essence, we've got Alzheimer's disease, but we've also got vascular dementia, mixed dementias, and it goes right down to frontotemporal dementia. So the reason you've all probably heard about Alzheimer's disease is because about 2/3 of people that are living with dementia have an Alzheimer's disease diagnosis. So it's the most prevalent form of dementia, but in essence, when we talk about dementia, we're talking about symptoms and we're talking about a range of disorders. So don't get them confused when you start to talk about dementia and Alzheimer's disease. So in essence, in thinking about defining some of the terms and the terminology then, in essence, dementia can be seen as the chronic and progressive mental disorders that actually lead to disruptions in a lot of your cognitive function. When it comes to Alzheimer's disease, then we're thinking a bit more about the targeted destruction, and it's very much similar to other forms of neurodegeneration. So it's thinking about the symptoms, but also thinking about the clinical onset of that disease that actually differentiates it between other forms of dementia per se. But the characteristic here is that these are progressive diseases. In essence, neurodegenerative diseases are, in essence, only going to get worse. And that's why your role as the pharmacist is to think about how you can best manage these patients that are living with dementia and Alzheimer's disease, but also thinking about what is the potential for the future in terms of actually treating patients who have yet to present into the GP with some of these deficits themselves. So why is it important that we understand the mechanisms and the biology of dementia? So in essence, this slide here just highlights some startling facts about why it's important to do that research, to understand what's going on in the brain, to actually then develop new medicines and potentially try to impact and potentially cure Alzheimer's disease and dementia. So in essence, now as of 2017, it's the leading cause of mortality in the UK. That's something to do with the change in terms of how you actually fill in people's death certificates, but that shows that it's actually contributing to a massive amount in terms of the mortality rate within the UK itself. In terms of the number of people living with dementia, and again, thinking about dementia as that global umbrella term, not just specifically Alzheimer's disease, you've got about 850,000 people in the UK suffering at this point in time. And that number, as you'll probably realise, is only going to increase as people live longer. Therefore, the incidence of dementia and Alzheimer's disease is going to increase. And again, it's something like 3.2 minutes. There's a new case of dementia going on. So you can just think, by the time you leave this lecture theatre, how many more people have been impacted by dementia and Alzheimer's disease itself. So now thinking about the impact, thinking about the societal impact and also the economic impact. What does this cost society in essence? What is the burden of dementia or Alzheimer's disease to us as a community as a whole? And this is just illustrated here in these graphs showing dementia alongside some of the other maybe more widely recognised disorders. And this is the economic burden to the actual UK itself, and this is in billions. So if you look across cancer, heart and stroke, dementia is the leading cost to our economy in terms of being able to support those people living with dementia through the actual care system itself. And that's why it's important that we think about trying to develop new medicines and actually trying to improve the quality of life for these people that are living with these disorders. Contrast that to the amount of money that is invested in the research to actually find these new cures, think about the biology, and then hopefully you can see that it's almost inverse. The amount of money we spend on dementia to find new cures or new medicines is pretty pitiful in comparison to the amount of money we spend on cancer. And the graph's not to say, let's cut the funding to cancer. It's just to say, look how far we've come in terms of cancer therapeutics with the amount of money we've spent. We understand a lot more about it. A lot more people are actually surviving cancer today than they did in the last couple of decades. Is that something we can now achieve with dementia if we try and actually match the funding in light of the fact that it's costing this amount of money to society? So that's just to highlight this disconnect between how much we spend and how much actually it costs us as an economy for dementia per se. So if you think about going back to the start, where did Alzheimer's begin? And some of you might have seen these people, or some of you might have seen this slide here. In essence, it was Alois Alzheimer's, who was a German physician or German psychiatrist, who actually termed the name Alzheimer's disease. And he was presented with this patient, Augusta D. So she was brought along to his asylum by her husband because she started to change and saw some change in personality and behavioural deficits. So Alzheimer's followed this patient along her journey in terms of in the clinic, and she sadly passed away. And then he looked into her brain. So he started to slice her brain and look at the actual staining within the brain. And here is where he started to picture some of these hallmarks of Alzheimer's disease. So this amyloid plaque, and indeed the tau fibrils or the neurofibril tangles. So even from an early age, and this is in the 1800s, we knew that there was something going wrong in the brain and there was some deposition of material within the brain. Questions? Yeah. So this is all post-mortem when she passed away, in essence, and this is now sort of slicing the brain to section it and stain for these plaques and tangles. So in essence, we knew that these plaques and tangles existed, but we didn't know what they were in terms of how they got there and how they actually started to accumulate within Augusta D's brain. If you look back and look at Dr. Alzheimer's notes, you can see that very quickly he understood some of the symptoms that we now understand to be representative of dementia and Alzheimer's disease. So in essence, there's cognitive symptoms. So that is, those are involved with executive function, including memory loss, which is one you've all heard about. But there are also ones about poor communication. There's also language impairment and also disorientation and confusion. So you can start to see how challenging these people are to actually deal with from a healthcare professional. But imagine you're a loved one that's caring for these people. There's an added burden as you see these people change in front of you. So that's the cognitive symptoms, but also you have the non-cognitive symptoms, which are also contributing to the change in these persons or these people's personality. So in essence, you see changes in the likelihood of depression, delusion, anxiety, sleep disturbances, and disinhibition. So these people become very different to the person that was pre-diagnosis or pre-dementia. And they become very aggressive, and that then leads to institutionalization, so going into care homes, and that, unfortunately, then leads to a more rapid decline in terms of their quality of life. There's also some disabilities that are associated with dementia as well. So again, once we start to put all these things together, you can see what kind of care package you'd be thinking to put in place to try and actually improve the quality of life and try to moderate some of the symptoms that these people are presenting with. So this is a complex individual you're dealing with, and it includes or it needs complex pharmacy or complex pharmacological intervention to get the right treatment for these individuals. So one of the problems that we have is trying to diagnose dementia or Alzheimer's disease. And one of your colleagues asked if that was post-mortem. Unfortunately, up until recently, that was the only tool we had in terms of confirming diagnosis of dementia. Getting someone's brain, slicing it, and looking at those plaques and looking at those tangles. And very often, you can see that there's some confusion in terms of those symptoms, in terms of some of the things listed here in terms of infection. So a lot of people confuse dementia and Alzheimer's disease with people who had brain infections because some of the symptoms were very classical presentations in terms of confusion and disorientation. And again, that maybe pinpoints to some of the etiology, some of the mechanisms of the disease process itself that might actually contribute to the disease itself in terms of inflammation. Your brain responding to that infection might actually lead and predispose you to actually developing these neurodegeneration or neurodegenerative disorders. So if we look at the brain of someone that's living or no longer living, but someone that has had a diagnosis of dementia. So hopefully you're all familiar with this, sort of the anatomy of the brain. So here on your left-hand side, my right-hand side is a healthy individual, an aged individual. So you can see the nice plump brain here. In essence, what you see here on the other side is that person living with severe Alzheimer's disease. So hopefully you can all recognize there's a severe shrinkage of that brain. You can see that there's a massive shrinkage in terms of the cerebral cortex, and there's much more pronounced sulci and gyri in terms of the actual folds of the brain itself. If you look here in the cross section that's shown below, you've got the ventricles here, which become much enlarged, and you've got this area here, which is the hippocampus. So again, thinking about Alzheimer's disease, thinking about dementia, one of the regions that is selectively targeted is the hippocampus. That's involved in memory formation. So that's one of the reasons why these people have problems with their memory. And in this severe case, what you can see is that this hippocampus here is almost ablated. It's almost completely destroyed. So in essence, you're getting a loss of brain matter. You're getting a loss of material from this healthy brain compared to this actual disease brain. And in essence, to put it in context, it's the weight of an orange that you lose. So if you think about how much the average adult brain weighs, does anyone know how much an adult brain weighs? Anyone hazard a guess? Who thinks it's more than 10 oranges?
300 grams.
300 grams. Who thinks it's higher or low? Who thinks it's higher than 300 grams? Who thinks it's lower than 300 grams? Okay, so it's about 1.5 kilograms. So it's about 12 oranges. Okay? So if you think about 12 oranges, think about the next time you go to the supermarket. In terms of dementia and Alzheimer's, that robs those people, those individuals, of one of those oranges. So just think about that the next time you're having your healthy snack in terms of fruit and an orange. So we think about touching base with these tangles and indeed plaques again. These amyloid plaques that we talked about that Dr. Alzheimer's actually observed under the microscope, these are made up of the amyloid beta protein. So a lot of investigation, a lot of research is now undergoing to find out what this amyloid beta peptide does. Why does it start to become these plaques or these sticky composites of protein? And how does that then disrupt and cause the neuronal cell death that you see evident that contributes to that orange being lost? On the other side, these neurofibril tangles is this tau protein. So this microtubule associated protein that actually becomes hyperphosphorylated in dementia itself. Can we actually look to see what is the biology of this tau protein and how can we actually manipulate it to actually potentially cause a reduction in some of these neurofibril tangles that we observe? So in essence, the toxic proteins that we're trying to work against is this amyloid beta peptide and this tau peptide as well. And that's some of the strands in terms of research and development are going in to try and work out how we can stop the processing of these two proteins to actually generate these plaques and these neurofibril tangles. So we think about diagnosis. How does someone eventually come out of the clinic or come out of the hospital with a diagnosis of dementia or Alzheimer's disease? So in essence, they'll be sort of referred from their GP to potentially a memory clinic. So we've got a memory clinic here down by psychology. So people might be referred to that memory clinic where they'll be then subjected to some tests, and that will give us a rating in terms of some of the clinical scales that you might be familiar with, and we'll touch on them in a minute. They might also go for some scans. So now, with improved technology and improved probes and actual differentiation, we can actually now start to look at those plaques emerging in living brains. So we now need to rely on those post-mortem samples to give someone a confirmed diagnosis of dementia. We can now use PET imaging or we can use MRI scans. But in essence, depending on where you are in the kind of country, it depends on whether you're going to have access to those scans and the relative likelihood of you actually being presented with that opportunity, and then the opportunity to follow that longitudinally to map the progression of the disease itself. So what do these tell you? So in essence, some of the memory tests are quite interesting in terms of what they can tell. So in essence, they're going to start to look at cognitive function, and they can look across several domains. So in essence, they can start to tap into some of the difficulties with language, some of the difficulties with spatial awareness, and those are some of the things that are teased out in the memory tests that you might have seen or you might be familiar with. In terms of scans, what you can see is you can start to quantify the changes in the brain. So we know there's some shrinkage in the brain. Can we actually measure that as the patient progresses through their journey with dementia? And again, some of the scans can give us an idea into some of those hallmarks of disease, that amyloid beta peptide and that tau neurofibril tangles in essence. In essence, some of the functional imaging can actually start to show some areas where we've got neuronal loss, where there's functional activity that is now no longer there. And you can use probes such as glucose to monitor neuronal activity and compare that across the different regions of the brain to see if there's any selective loss of neurons within particular regions of the brain. And that can then give you a bit more of a diagnosis as to the particular form of dementia that someone suffers from. Whether it's Alzheimer's or whether it's frontal temporal dementia can actually be ascertained through some of the imaging techniques that can be employed. So I don't know, some of you might have heard of, or some of you might be familiar with this MMSE, this Mini Mental State Exam. So in essence, it's a little questionnaire, and then it's scored out of 30. And again, it touches on several of the domains we mentioned in terms of orientation, registration, language, etc. And then you can see there's a scale that accordingly puts you into a clinical category depending on the outcome of that score. But as with everything, it's not perfect. In essence, it's a very rigid scale in terms of scoring out of 30. So in essence, there are grey areas in terms of someone progressing down that scale in terms of transferring from MCI, mild cognitive impairment, to moderate impairment to severe impairment. So that's why there's other tests that are being used, and you might have heard of some of the ADAS-COG and the MIDAS as well, are two different tests that you can use. So in essence, while this still remains the kind of most widely used ones, there are different tests which are a little bit more sensitive to some of the actual changes that you can observe through simple tests such as these. So this is another one that you can use, and in essence is a very simple test. It's getting someone to draw a clock. Hopefully, although it's late on a Friday, this should be something that you should all be able to actually do and accomplish quite readily. But people living with dementia and living with cognitive impairment actually struggle with drawing these clock faces and showing the hands at the correct time. And you can see that as you go from Alzheimer's disease and you go from something that is a mini mental state score here of 21 to something that is 25, you see there's discrepancies in their ability to draw this clock face. And more interestingly, when you start to think about trying to get something that diagnoses between the different dementias that we talked about in the introductory slide, someone with frontal temporal dementia actually struggles to put the clock face in any orientation itself. So while it's simply drawing a clock, this is a very informative test in telling you whereabouts in the brain that disease is targeting, and therefore actually can then think about further clinical tests that you could employ to actually confirm that diagnosis. Just thinking about following that pathology. So we know at the end stage, at the post-mortem tissue, we've got these pathological plaques and tangles. How do they get there? And what is it that actually stops that journey to actually making some of those toxic peptides aggregate and build up within the brains of these people that suffer from these neurodegenerative disorders? So if you look at the age here, so this is the age of the individual, and again, most people suffering or living with dementia are over 65. There is the exception of those that have early onset disease or Alzheimer's, and that potentially hits people around about 35. So it's not just a disease of the elderly, but it's predominantly those that are affected, and that's, again, a risk factor which we'll touch on. So if you go, say, 15 years or 20 years before your diagnosis, what you start to actually unpick is, here is this amyloid beta. So your amyloid beta is starting to actually make those plaques, and this is, in essence, a marker in terms of a level of that biomarker that's present. So in essence, amyloid deposition starts and then becomes toxic or becomes actually something that we can actually detect when the actual patient goes through those kind of tests and symptoms actually display. And you can then track the other, in essence, cohorts as well, in terms of some of the language deficits. And this is looking at some of the actual PET imaging as well to look at some of the other hallmarks that we're interested in. So what you can see is all of them start well before someone goes through the door to the doctors to say, I think I'm having problems with my memory, or some behavioural changes, send them to the doctor. It's how we can actually find out about these patients or these individuals before they get to this point where we've seen that massive neuronal loss, that atrophy of the brain. Therefore, we're fighting a losing battle in terms of trying to preserve actual brain function itself. So how do we follow pathology? So we touched on PET scans and MRI. So the top one here is just showing some examples of MRI images. And in essence, that can be used, as I said, to quantify some of the changes you see. So you might be able to pick up some pre-symptomatic changes that are occurring that might want to then send you for further tests to try and see, in essence, if this is something that's likely to lead to, in essence, a dementia or Alzheimer's diagnosis. It's non-invasive, as you say, so it's pretty easy to actually administer, putting someone in a scanner and then getting the results as well. And it also affords the opportunity to actually monitor longitudinally what's going on to those individuals' brains as they progress, maybe from the mild cognitive impairment to moderate impairment to severe impairment, if there are actually changes that map on in terms of the volume of the brain that is evident in these MRI scans. The other opportunities that you have in terms of this functional imaging is, in essence, FDG, and that's looking at glucose utilization. So you can start to then map out the brain areas that are active, and here are the signaling. So the red areas here are areas that are pretty active in terms of stimulating a task. And you can see as you go from control through to dementia, you get this decrease in activity. So it's measuring almost the metabolic status of the brain, and we're using that as a readout of neuronal activity. So this can start to tell you a little bit about regional specificity. Where is the specific deficits in these patients' brains that actually are leading to some of the symptoms that they're presenting with in the actual clinic itself. So one of the big questions that everybody asks is, what are the risk factors? Is it me or something that I'm going to experience in my life that actually is going to contribute to my dementia diagnosis? And in essence, these four bubbles highlight, in essence, all the different factors that contribute to your risk of actually developing Alzheimer's disease itself. So as we touched on here, the major one is age. So again, the predominant risk factor for dementia and Alzheimer's is age. With over 65s, actually the risk starts to double every 5 years. So you can think about as you progress, the likelihood of you developing dementia also increases. And that's why with people living longer, more incidences of dementia are actually reported. There's genetic components as well that we know of. So I touched on that early onset in terms of the dementia and Alzheimer's disease. So we know that they are predominantly governed by genetic mutations. And we'll touch on them in a little bit. In terms of the sporadic form that affects the elderly population, we know that there are some genetic risks, but there's no single genetic mutation that will lead to the definitive dementia or Alzheimer's diagnosis. And that's the problem. So there's not one particular, will it be age, will it be lifestyle, smoking, drinking, will it be genes, or will it be environment that actually guarantees you to then convert to a diagnosis. So in essence, it's a contribution of all these different factors that then accumulates in an overall risk in terms of your likelihood of actually going on to get dementia. So in essence, here are some of the risk factors we touched on. So again, age over 65, this apolipoprotein E4 genotype. So that's a gene that's involved in regulating lipid metabolism within the brain, such as cholesterol. And we know that it comes in different isoforms, and the E4 isoform is one that actually increases your genetic risk of going on to develop Alzheimer's disease. The ApoJ genotype, this TREM2 status. So this is a new and a recent discovery looking at some of the different cell types within the brain. So starting to understand not just what the nerve cells do, the neurons that die, what about the microglia and the astrocytes? How do they contribute to the disease process itself? And this TREM2 actually encodes for a protein that is located on the microglia. So it suggests there's something about the inflammatory status of the brain that may predispose individuals to going on and actually converting to dementia. We know that a history of stroke. So in essence, if you have a stroke, the more likelihood is that you'll then go on to develop a neurodegenerative disorder. Thinking about a stroke, in essence, it's lack of oxygen, it's a hypoxic episode. So you can start to then try to understand what does that hypoxia do to nerve cells and do to the surrounding cells to actually then see if that's a secondary insult that actually leads to those amyloid plaques building up and also the tau neurofibril tangles. Vascular disease, head injury, diabetes, smoking, drinking, education all play their part. And the graph down here just highlights in terms of the cognitive reserve. So in essence, two groups of subjects, some with high reserve and some with low reserve. In essence, they end up at the same point, but the trajectory is slightly different. So that's why some people's rate of decline is much more rapid than others. And again, that's again thinking about how you're going to manage those individuals and thinking about a more personalised approach depending on where they are on the scale and how quickly they're likely to deteriorate. Yeah.
What do you mean by education as a risk factor?
So in terms of education, how educated you are can actually have an impact. You know? So in essence, there was a study that was just out in the Lancet last year that shows on your life trajectory where things can actually impact. So education in the early years, unfortunately we're thinking about school rather than university, can have an impact on you going on to develop. That might also be entangled in terms of social economic status, but in essence that's the way that they were looking at it in terms of education. So one of the things there was that we mentioned was head trauma. So in essence, this dementia pugilistica, in essence, is punch drunk. And so people started to look in terms of post-mortem tissue to look at brains of people who had been, in essence, boxing or people who have been involved in traumatic injuries. And so what they found was, and this is again post-mortem tissue, looking at neurofibril tangles. It's looking at those tau protein aggregates to see if there's any hallmarks of pathology within these individuals' brains. So this in essence is the 77-year-old boxer. This is a 47-year-old who had, I think, one traumatic brain injury, and this is a 63-year-old boxer. But this is just to highlight the fact that, in essence, traumatic brain injury starts to generate some of those tau neurofibril tangles that are characteristic or hallmarks of dementia itself. So you can see that there is actual commonalities in terms of the disease progression and actually the end stage that actually ends up with these tau proteins or tau neurofibril tangles. If you think about the genetics, this is just a kind of timeline to when we found out about some of these genes and when we actually started to understand what they were all about. And so what you can see up here is in essence the APP, the amyloid precursor protein, which we'll touch on in a little bit. and we've got the PSEN1 and PSEN2, which are presenilin-1 and presenilin-2. And those are the ones that contribute to that early onset disease. So that initial Augusta D picture, people have gone back and looked at her brain. She was, I think, 38 when she was taken to the clinic, and in essence have found that she had mutations in her amyloid precursor protein, or the presenilin actual proteins themselves. So you can see the list of different genes that are actually becoming involved, and it gives you an idea in terms of what some of those actually do biologically. So everyone always asks in terms of risk factor, how popular, or in terms of the population, the frequency of these actual genetic variants. And again, this is a nice little infographic, I guess you can call it, from one of the leading charities, the Alzheimer's Research UK, and it shows the TREM2, which we talked about. So this is the microglial protein, or the gene that encodes for the microglial protein. This is this ApoE4 that we mentioned, and these are the other ones that I mentioned in the previous slide. And then these are the presenilin mutations in the APP. So these cause the disease. These down here actually increase the likelihood, that risk of going on to actually develop dementia itself. So just touching on that ApoE status, in essence, thinking about ApoE4, how can you monitor that? Thinking about some of the things we've talked about in terms of the scanning. Here we've got PET measurements, so you can actually start to label this amyloid beta peptide. And again, that gives you an insight into how this brain, or how these patients' brains are actually developing these plaques. So in essence, we've got no ApoE genes, so that's again, someone's clear. If you've got one of the ApoE genes, that increases your risk. You can start to see that there's some deposition of amyloid. 2, that increases the load, and then this is someone in comparison that has clinical Alzheimer's disease. So you can see that you're starting to increase the burden of the amyloid load in these people that have 2 copies of this ApoE4 allele in terms of that genetic risk factor, but it's still markedly different from someone who has clinical Alzheimer's disease itself, suggesting that there's something else that then would convert these people to a definitive diagnosis of Alzheimer's disease. So focusing on the amyloid beta peptides, we know that's one of the toxic peptides that we've talked about that provides those hallmark plaques in the brains of these individuals living with Alzheimer's disease. So what we've got here is this APP. So this is this amyloid precursor protein. So in essence, this is a transmembrane protein that sits in the membrane and in essence is processed by cells. There's 2 routes that it can take. So as we sit here, hopefully our brains are processing it down the non-pathological pathway. So this APP actually is then converted with alpha secretase and then gamma secretase. So these are enzymes that cleave this amyloid precursor protein. And as you can see, it cleaves it at different points. This then releases this soluble amyloid precursor protein, this P3 and this C59 fragment. And that's how normally APP is processed, and cells are able to cope and degrade this APP processing, or APP peptide. In terms of what happens in the pathology, what you find is it's a different sequence of events that occurs. So in essence, where the alpha secretase starts to chop first, for the non-pathological, this beta secretase, or base, comes in first. That's then followed by the gamma. That then leaves this red fragment, the amyloid beta peptide, and that runs in, released into the extracellular space. So simply by chopping this APP at different places using a different combination of enzymes that leads to the generation of this amyloid beta, and that's the toxic form of the amyloid beta, that then starts to aggregate. So in essence, that's a monomer, it becomes a dimer, trimer, oligomer, which then actually folds and becomes what is represented in these plaques that we see at post-mortem. And in essence, what we know in terms of the pathology and the genetics is that there's mutations in APP that affect this processing, and there's presenilin mutations that affect the gamma and beta secretase enzymes. So it affects the cleavage of this. It allows more of, in essence, the pathological form to be generated rather than this non-pathological. Question? Yes, yeah. So in essence, they still have alpha, but beta secretase becomes more predominant. So it overrides this alpha secretase. So in essence, the mutations that occur in terms of the disease actually lead to the predisposition of this beta secretase. So it enhances the activity of this beta secretase. So this becomes much more efficient, this pathway, than this pathway in terms of the disease process itself. So this has led to, I guess, decades of work figuring out what amyloid does to cells, and how can that then lead to mass destruction of neurons that we see evident in some of those the gross anatomy pictures we showed earlier. So there's two things that can obviously happen to amyloid in terms of giving you that elevated levels in the actual plaques that we see. One, you can ramp up production, so you can start to increase the amount of amyloid beta that's present. Or conversely, you can start to shut down degradation. So actually dysfunction of the clearance mechanisms that normally are in process can actually contribute to Alzheimer's disease itself. And then this has come together to form what we know as the amyloid cascade hypothesis. So in essence, you get this increase in A-beta accumulation, it starts to aggregate, so starts to become those oligomers, and we believe that those are the toxic entities in terms of amyloid beta itself. That then induces an inflammatory response. So again, where we've got some commonalities with infection, this might be the point at which we see that crossover in terms of infection and the inflammatory response to this amyloid itself. This also is where glial cells come in. So we touched on microglia, we touched on astrocytes. This is why we're interested in these cell types and how they can actually be potential targets for new drugs and strategies to actually prevent the neuronal destruction, which is the endpoint. If you can start to manipulate cells which are a little less sensitive to interventions, you might have a way into actually forming a new strategy to actually protect the nerve cells from the destruction by this amyloid beta peptide. You then start to get synapse loss. So one of the very early indicators in some of the animal models that we use to actually study dementia and Alzheimer's disease is synaptic loss. And again, that's something that's carried forward in terms of the human disease as well. That leads to oxidative stress, so that build-up of reactive oxygen species, and neurons don't like that. That's something neurons are very sensitive to, and that ultimately leads to calcium overload. So the influx of calcium, and again, hark back to maybe your second year lectures, that process called excitotoxicity. Influx of calcium through NMDA receptors leads to, in essence, cell death because it becomes uncontrolled, because you get an increase in the levels of glutamate that are circulating within the synaptic cleft itself. So that's the kind of flow diagram, if you like, of the build-up of amyloid beta peptide and the end result, which is that neuronal death, which is evident in dementia and Alzheimer's disease. So this is where it takes a kind of a sad or a turn for the worst, so to speak. What is it that you as a pharmacist can offer someone living with dementia? Unfortunately, not much in terms of disease-modifying therapies. So there's nothing that you can give to someone living with dementia that's actually going to alter the course of that disease process we've just talked about. Therefore, you're thinking about how you can then manage the symptoms that actually the disease presents. And a lot of the the current strategies and the current drugs that are recommended focus on neurotransmitter systems, focusing on glutamate and hopefully your favourite from second year, acetylcholine. And in essence, that's where the role of the pharmacist comes into play in terms of actually using these medications and using them where appropriate. So hopefully, this is a bit of revision in terms of this synapse, and in essence, we're modelling the cholinergic synapse here. So in essence, we've got our presynaptic terminal, we've got our postsynaptic terminal, we've got our different array of muscarinic receptors, and we've also got our nicotinic acetylcholine receptors. And in essence, what we're looking for is acetylcholine to be released, head across, and actually then target this postsynaptic membrane to allow that signal transmission to occur. Hopefully you're all familiar with some of the partners in crime in terms of choline transporters, acetylcholine A, choline, and actually the packaging. And then the one we're interested in terms of dementia is the enzyme that's involved in breaking down this acetylcholine neurotransmitter. So one of the problems in terms of dementia and Alzheimer's brains is the loss of acetylcholine and the loss of acetylcholine neurons. So in essence, you want to boost that signal from pre to post synapse, and the way you can do it, in essence, is by targeting this acetylcholinesterase. So if you can inhibit the breakdown of acetylcholine, that will then lead to potentiation of the acetylcholine that's in the synapse, and then afford better signal transmission than you would have as there's depleted levels of acetylcholine. So in essence, this is a major target for some of the drugs that are out there in terms of managing the symptoms of dementia. So what you've got out there in terms of acetylcholinesterase inhibitors are donepezil, galantamine, and rivastigmine. And again, what you're trying to do, in essence, is to enhance that signal transmission that's mediated through acetylcholine. One thing you can always think about is as the progression of the disease increases, so does the neuronal loss. If you're then trying to target, boost acetylcholine transmission, then the effectiveness of those drugs is going to wear off in time. And that's what you see as, in essence, people progress with their severity of the disorder, that these drugs start to become less effective. It doesn't, again, prevent progression of the disease, so these people are still going to get worse in terms of the dementia diagnosis. They're on a journey in terms of that destruction of the brain tissue that these drugs will not halt. And again, what you find is that only a subset of patients respond. Remarkably, it's about 40% of people living with dementia respond to these drugs. And in essence, respond, and that's saying respond in a good way. Because again, thinking about things that moderate cholinergic transmission, you can have some side effects that hopefully you're familiar with through the muscarinic system in terms of nausea, vomiting, and diarrhea. So in essence, some of these drugs aren't very nice in terms of some of the side effects they take. And that has to be weighed up with the quality of life or the improvement of quality of life that you're getting from taking these particular drugs for these particular patients. So one thing to think of and to be aware of as a pharmacist is this anticholinergic burden. Is that something you've heard of before? Hands up. Some people have. One person has. Excellent. So in essence, you're starting to modulate the cholinergic system. You're trying to boost transmission. But in essence, there's a whole host of other drugs that are trying to dampen down cholinergic transmission, so the anticholinergics. So when you're starting to treat people that have a diagnosis of dementia, Alzheimer's disease, you have to think about the drugs that you're giving them. So you might have to undertake medicine review to think about, this person now has a diagnosis of dementia, are there better drugs they can be on to actually manage their other ongoing issues? Because in essence, because of the age indication, elderly people are likely to suffer from other disorders, whether that be cardiovascular or whether that be neuropsychiatric disorders, and also they have problems actually then starting to metabolize drugs themselves. So again, it's to be aware of that actually these things can actually add up, and it can actually give you this score or clinical rating that actually says that you need to change the medication. So it's briefly just to mention here, and we're going to touch on this again in your IPE activity, in terms of thinking about some case studies, thinking about are there better drugs that you can use to treat some of the other ongoing issues with this particular cohort of individuals. But just to indicate, you get scores of 1 through to 3, and that's where you can think about changing the actual medication itself. In terms of glutamate, again, this is something that you should be familiar with in terms of the glutamate transmission synapse. Again, we're going across and we're acting on potentially metabotropic glutamate receptors, NMDA receptors, or AMPA receptors. And in this case, what we're looking to do is to try and boost the glutamate signal itself, but in essence, we're trying to dampen down that excitotoxicity through these NMDA receptors. That'll then lead to an increase in transfer from this glutamate into these astrocytes. So remember, these transporters taking up glutamate to actually then clear the synapse itself. So one of the drugs that you'll be interested to hear about, and you'll also maybe recognize, is this antagonist, this memantinine. And that, in essence, targets the NMDA receptor itself. What it does is improve cognitive function. Again, there is some evidence that it's better at late stage, but again, that's not robust data sets. So speaking on it, it might be that it's just on an individual basis. And again, it certainly doesn't prevent the progression of the disease itself. But then also to think about modulating glutamate transmission may have also knock-on effects in terms of antipsychotics, anticoagulants, and indeed muscle relaxants itself. So I guess this is the take-home message that you need to remember in terms of when you're going to use the particular drugs that we've talked about. So current guidance for donepezil, galantamine, and rivastigmine is for managing mild to moderate Alzheimer's disease. Memantamine is now recommended as an option for moderate, severe, and potentially in combination, but that's not a current recommended treatment. And again, for those 40% of individuals, or 60%, 40% of individuals, who don't tolerate or don't respond to those acetylcholinesterase inhibitors, memantamine can be an alternative option for you to look at. Novel strategies, so thinking to the future, there's potential to think about targeting all of these strategies, modulating neurotransmission, amyloid-based therapies, so trying to think about how you can actually destroy the amyloid plaques themselves. Is there ways to get that? Well, that's a vaccine or an antibody. Clinical trials are underway. Some of the things that are sort of new and thinking about is anti-inflammatory therapy. So can we target those microglial cells, that inflammatory component, to dampen down the response to actually afford protection to the nerve cells. And it's thinking about drug repurposing. Are there already drugs out there that could potentially have an impact in terms of that dementia diagnosis? And some of the drugs that people are interested in are those that treat diabetes. So can some of the diabetic drugs, metformin, actually have an impact in terms of stemming the tide in terms of dementia per se? And that's a picture of Laura. So in terms of the strategies, this is just a table to highlight where we are. There'll be no surprise that the small molecules that you're aware of in terms of your second year lectures, there's in essence the majority of them are going through clinical trials at the minute. 65 have been discontinued. There's some antibody-based therapies and there's some RNA-based or DNA-based therapies as well. So it gives you an idea of the scope of some of the treatments that you may be actually dispensing come your time in pharmacy practice. So just maybe to sum up, to think about where the future lies. 2017 was a sad year again in terms of where we are in terms of new therapies coming onto the market. So this solimumab, this Eli Lilly drug, was an anti-amyloid therapy. It was an antibody that could bind to the amyloid beta peptide and actually inhibit its aggregation. It inhibited its aggregation, but it didn't actually then afford any benefit to the patients themselves. So that can calls into question the amyloid hypothesis and whether you actually modulate amyloid load, will it actually give you any restoration of cognitive function or indeed brain performance? And then there's another drug that failed as well, this BACE inhibitor. So beta secretase is known as BACE. So again, modulating that amyloid precursor protein or amyloid beta processing actually didn't work either. What is currently up for grabs is a seat here, which in essence is this neuro AD system, and it involves a combination of this cognitive behavioural therapy, and in essence, it's approved in Europe, but it costs £5,000. Yeah, £5,000 for a 6-week session, and there's no longitudinal evidence to suggest that this is actually going to make you better in the long run. Some of the short-term studies suggest that it gives you moderate benefits in terms of quality of life. But again, it might be that it's for those that can afford it, so to speak, rather than being something that everybody has access to. And then just to finally touch on the non-cognitive sides, to thinking about these BPSDs, so those behavioural psychiatric symptoms of dementia. So again, agitation, anxiety, hallucination, aggression, that leading to the actual majority of in essence, the challenges that these patients present is their behavioural symptoms. And thinking about how you can manage that, that may actually improve quality of life for the individual and also for the people that are caring for them. So thinking about what's in the best interest of that patient and indeed those around them to actually modulate or manage their condition better. Those things that are on the radar or should be on your radar in terms of things that you can opt for, in essence, antipsychotics, sedatives, and antidepressants. So there are things that you can actually contribute to actually manage those behavioural symptoms better. One of the key things there is to highlight is thinking back to that anticholinergic burden. Some of the drugs that you might be dispensing might actually impact on that cholinergic burden scale. So again, these are some of the areas in which you can start to think about changing medication. So they might already be on an antidepressant before their diagnosis of dementia. It might be something that you have to change following their diagnosis of dementia. So just a final signpost in the road to say that we're going to be following up on some of this and thinking a bit more about the pharmacy practice and the challenges that you'll face in a multidisciplinary team in terms of the interprofessional learning workshops in February. Hey, how you getting on?
I was just curious if you know if the article I sent you about the Physiology Friday event was published. Because I keep checking that physiology blog, but I can't see it.
So they're putting it together in terms of a package of Physiology Friday.
Yeah.
So it's not going to go up on the blog. It's going to go up on a more what's the word? A more prevalent document in terms of everything that was Physiology Friday related, so to speak. So it's not going to be. So it's not going to be individuals. It's going to be what happened in Edinburgh, what happened in Reading, so they're putting it as a sort of a data pack or pamphlet to then publicise it for next year. So it's speaking on.
Okay.
So we haven't forgotten about you. So it's still
No,
there.
sure, I was just curious.
Yeah. And so the other thing, I'll send you the link when it goes live, is that they're putting up on the Reading Connecting Research Forum blog.
Okay, great.
Yeah?
Perfect.
Okay. Question?
Yes.